what really good rugby league team won on the weekend? I'll help you, St George. And David comes from the St George area, and we're very pleased to have him here. He is a PCFA colleague, a fellow director, and David chairs the Awareness and Education Committee of PCFA. So we are very privileged to have such a person address us tonight, and we're looking forward to his presentation. And we're also looking forward to, as we always do, to the question and answer session.
Well, first of all, thank you, David, for that very kind introduction, and Pam for the invitation to come and talk today. I'm talking about localised disease, but I'm going to probably just broaden the envelope a little bit, cast the net a bit wider, and start talking about the prostate in general, because I'm sure for many of you gentlemen it's a very familiar organ, but for some it might not be. And even for those that have been through the ringer of treatment, there's probably still a few unknowns. And as I was driving up here, it occurred to me I have been here before. It's got to be at least 10 years, shortly after I came back from my training in the United Kingdom. And a lot's happened in 10 years. I've got 2 extra kids. I've got a few more grey hairs, but I've actually had my first PSA test. And being over the age of 40, it was a smart thing to do. And you can largely ignore what the press has been saying lately. The US Preventative Task Force has come out and basically said that at this point in time they cannot justify mass population-based screening. And nobody's saying that mass population-based screening should be implemented. But if you use PSA in a clever, in a sensible, in a practical manner, it's a very powerful tool. You combine that with the recognition that not everybody needs to be treated. You come up with a situation where you're maximising the good and you're minimising the harms of treatment, and that's clearly where the management of localised prostate cancer is going. And with David as the sort of the chairman of the PCFA and a lot of fairly clever medicos, myself excluded, sort of working on the science in the background, I'm sure we will continue to make some inroads into this sort of very common, very prevalent and insidious disease, which we all know, if it's found early enough, can be treated with very good outcomes. So we are all heading in the right direction, and we'll continue to sort of make those inroads to get public awareness and political awareness of the role of the importance of the disease in the community. Anyway, and I'll get off my soapbox.
No, but that was a good way to start.
Yeah. We'll all join you on your soapbox.
A little bit of anatomy, guys and ladies and gentlemen. You've got, this is the sort of the male genitourinary tract. And we say genitourinary because there's a urinary bit and there's a genital bit, and it's got a reproductive and a sort of an excretory function. You've got 2 kidneys, big blood vessels called the vena cava and the aorta. You've got 2 ureters that bring the urine down from the kidney, and they track in the back part of the abdominal wall, so all the bowels at the front and all the muscles are at the back, and these run along the back of the abdominal wall into the bladder, and then the water pipe, the urethra, runs through the prostate. So here's the little organ himself, the troublesome one, and out through the penile urethra. And then you've got the reproductive bits, which include the testes and the vasa. And the sort of the reproductive bit and the urinary bit come together in the region of the prostate. So what is the prostate gland? It's a donut-shaped organism. In a young chap like myself, it's about walnut-sized. As you get a bit older, it gets bigger, and it gets bigger under the influence of the male hormone testosterone. And almost all men will have some microscopic evidence of enlargement of the prostate. And it's actually one of the reasons why your PSA is allowed to be a bit higher as you get a bit older, because there is a natural enlargement of the prostate, and BPH, or benign enlargement of the prostate, makes PSA as well. It is deep in the male pelvis, which means access is a problem. It's like getting here tonight. And one of its main role is to provide a healthy environment for the seminal fluid. And specifically, if we didn't have a prostate, if we didn't have that healthy environment, the human race would sort of grind to a halt in 1 generation. So it's a fairly important organ. What can happen to the prostate? It can become enlarged. That's a non-cancerous enlargement of the prostate. We call it benign prostatic hyperplasia, or BPH. And if you've got BPH, you might have symptoms that go with with BPH, and they are called lower urinary tract symptoms or waterworks symptoms. It can also become infected or inflamed, which is prostatitis, and of course it can develop a malignant or cancerous change and become prostate cancer. So what I thought we could try and talk about tonight is what actually is prostate cancer, how common is it, what are the risk factors, and touch on a little bit of the treatment, the testing debate and dilemma, and then of course treatment options for localised disease. Well, essentially the prostate has glands, and those glands make the fluid that provides a healthy environment for the semen or the semen or the sperm. And those glands can become abnormal. And a cancer cell is basically a cell that loses the usual control mechanisms. Now that means a normal cell, be it a skin cell in the mouth or on the skin or even in the colon or somewhere like that, it has a lifespan. It might a lifespan of two months, it might be a lifespan of 2 years, depending on the tissue. But all cells are programmed to die after a certain period of time, and then they get replaced by another healthy cell. Now, a cancer cell is actually a cell that loses those control mechanisms. And so they basically, they don't have the programmed, they don't develop a use-by date, so they just keep growing and growing and growing, and they develop the ability to spread to other parts of the body, or they develop metastatic potential. They infiltrate through normal tissue planes, and then they can spread. And that's basically what a cancer cell is, a cell that's lost its normal control mechanisms. Now, what we know about prostate cancer is that some are relatively well behaved and some are relatively poorly behaved. And we'll talk about the behaviour and how we grade those tumours in a few minutes. Unfortunately, in the year 2012, all treatments do have side effects, but we do know that the earlier you find prostate cancer, you can minimise those side effects and maximise quality of life outcomes. And unfortunately, some prostate cancers are nasty from day one. And I actually 2 hours ago, I saw a GP, a 61-year-old GP who's been sending me patients for the last 10 years. And about 3 or 4 years ago, his PSA was 1.7. He'd forgotten to get a couple of PSAs done, and he rang up in a bit of a panic today because his PSA was 827. And of course, he's got lymph nodes, he's got a positive bone scan, and we can treat him, but we can't treat him to cure him. We can treat him to control the disease. And so even with, and that's a really good example of how even with regular prostate cancer screening, some of them are going to slip through the net because some of them are just nasty. And we try and sort of come up with a program or a management program that's going to try and capture as many people as possible. But every now and again you'll get someone like this poor old GP I've seen, last patient today, who's going to struggle in the medium term despite his best efforts to stay on top of the problem. And that's why getting to the genetic heart of the disease and prevention is always going to be better than cure. And obviously that's where we want to try and get to in sort of years ahead. It is a very common condition. 1 in 8 men will develop prostate cancer. But as you guys would know, if you've got a family history, if you've got a family member, your risk of developing the condition goes up. And certainly when I see a patient, and I've seen a patient relatively recently, who said his 3 brothers have all got prostate cancer, and he's sort of 45. Well, it really is a matter of when, not if, he's going to develop a problem. And certainly the more relatives you have, the more likely you are to develop the problem. And interestingly enough, the genetic nature of that disease is very similar. So if your dad gets it when you're 70, you'll probably get it when you're 70. And of course, what we tend to see is that the dads who are 70 and 80, it wasn't picked up as early as it might have been. And so the kids are getting it when they're 50 and 60. And there's that 10 to 15 year period where it goes from sort of being localised to being beyond the prostate. Now, the rate is increasing. It's not just increasing because we're looking for it. So the incidence is going up, but actually the underlying background rate appears to be going up. But fortunately, the mortality is decreasing. And I think the early detection and early intervention is leading to a very clear reduction in the number of men dying of prostate cancer, both in the States and Australia. So a few more numbers. I mean, these are straight off the PCFI website. 20,000 Australian men will be diagnosed with prostate cancer this year. About 3,300 men will die of prostate cancer this year. And it's very important to make people aware that the same number of men are dying of prostate cancer as there are women dying of breast cancer. And that's a sort of a fairly sobering statistic. And it also, people are surprised, and I guess that reflects the lack of awareness in the broader population about the condition. And of course, you're more likely to get it as you get older. And 1 in 9 Australian men will develop clinical prostate cancer by the age of 75, and 1 in 5 by the age of 85. Now, a few more sobering statistics. If you do autopsy studies on 40-year-old men, so someone wraps themselves around the telegraph pole, unfortunately, on a Friday night, and you look at their prostate under microscopic sort of conditions, 30% of 40-year-old men have microscopic prostate cancer. 70% of 70-year-old men have prostate cancer, microscopic prostate. 100% of 100-year-old men have microscopic prostate cancer. You get it as you get older. I tell my patients it's like wrinkles on your skin. Now, it's one of those things that's going to happen. Now, my job as a urologist is to identify those people who are at risk of dying of their condition, of having their life shortened by undiagnosed disease, and then reassure those people that aren't at risk, who have very low risk tumours, that it can be safely watched. And that's really the change in the management over the last 5 to 10 years, is that we realise not everybody needs to be treated immediately, and many people might not need to be treated at all. If you look at some of the studies coming out of Europe at the moment, where they've been conducting studies into screening, we recognise that up to 40% of the tumours that we're currently diagnosing are low risk or very low risk cancers, and they might not need to be treated for 15 to 25 years. So I think as it stands at the moment, what we need to be doing is trying to find it in people, but not over-treating people. Ideally, we wouldn't actually be finding those low-risk cancers, but at the moment the best test we have is PSA testing, and in 2012 we should be very conscious about not over-treating people, but certainly not under-treating people. So are there any symptoms? Well, there can be symptoms, but unfortunately if you develop symptoms it's often a little bit late. But you might have some blood in the urine, you might have some waterwork difficulties, and certainly symptoms related to enlargement of the prostate can coexist with symptoms related to, in a gentleman who might have some prostate cancer. So just because you've got plumbing problems doesn't mean you've got prostate cancer, but if you've got plumbing problems, a urologist is going to make sure there's nothing else going on. Certainly there might be a family history, and many men don't have any signs at all. Now, how do we determine if someone does have prostate cancer? Well, we can do a blood test, and I'm sure I'm preaching to the converted. Actually, I was giving a talk yesterday. I was asked to present a talk to the Pharmaceutical Society of Australia. And if you think about that for a minute, what the initials might be. So here I am giving a talk to the PSA about PSA. But anyway, I digress. So the blood test, and we use a blood test called PSA, which is the most reliable test we have at the moment for detecting prostate cancer. It should be combined with a digital rectal examination. And I know some GPs don't like to do it, but the reality is around about 1 in 20 prostate cancers don't make PSA. And often they're the nasty ones. And so if you don't do a rectal examination when you do a PSA, you're going to miss some prostate cancers, and you might miss the ones that have the potential to cause harm. And I say that doing a PSA test or doing a DRE raises a red flag. Having an abnormal PSA does not mean you've got prostate cancer, but it means it needs to be ruled out. And so the red flag is raised, and we do another test called a prostate biopsy. It can be done under local anaesthetic, it can be done under general anaesthetic, and as I'm sure you would know, it involves using an ultrasound probe placed into the backside, and then we use that ultrasound probe to guide biopsies into the prostate. The biopsies might be done through the backside, called a transrectal biopsy. The biopsies might be done through that bit of skin behind your scrotum, called a transperineal biopsy. There might be different approaches for different people, but the reality is a biopsy is the gold standard for diagnosing prostate cancer. So a little bit more about PSA. It stands for Prostate Specific Antigen. So it's not prostate cancer specific, but it's prostate specific. Its role is actually to liquefy the semen. Now, we've all cut ourselves shaving and we wait long enough, providing we're not on warfarin or Plavix or any other antiplatelet agent, you're going to stop bleeding and the blood forms a clot. Now, if you didn't have any PSA, your seminal fluid would clot the same way that blood clots outside the body. And so it actually provides a healthy environment for the seminal fluid. Most of the PSA is actually present in the ejaculatory fluid, but some of it leaches into the bloodstream and we can measure it and at very low levels. But we've got clever tests and we can work out what the normal range is and we can work out what the abnormal range is. And certainly the higher the PSA, the greater the risk that there might be some prostate cancer present. So it's not really a true cancer blood test, but it certainly is the best test we have in 2012 for identifying prostate cancer. Now, I mentioned before we have normal ranges, but in the last couple of years we've also become very aware that the median PSA is very important. Now, looking around the room, okay, most of it are going to be that 50 to 59-year-old age group. There you go. So, your PSA using the common assay is usually going to be under 3 nanograms per mil. And when you get a bit older, it can go up a bit, and when you get a bit older again, it can go up a bit higher. And certainly, the older you are, the higher you are allowed to have a PSA without any suspicion of a problem. But if you look at these median numbers, you can see that they're actually much lower. And those of you that remember a bit of statistics, you talk about median is the mid-range PSA. So that's where if you had 100 people with a normal sort of range of PSAs, the 50th result is going to be the median result. And what we know is that if you do median PSA, you can risk stratify people. And this is where it gets a bit interesting. If I do a PSA test on a 40-year-old male and it's below 0.65, I know that he's actually at low risk of developing prostate cancer in the next 20 to 25 years. If I do that same PSA test on the same 40-year-old male, but it comes in at 1.2, it's still within the normal range, but his risk of developing prostate cancer over the next 20 to 25 years is about 6 to 8 times the rest of the population. So this is where you may have heard that there's a trend to do PSAs earlier, and that's because we can actually predict who's at risk and who's not at risk, and we can actually then say, okay, you're 42, we're going to look at you every sort of 1 to 2 years for the next 20 years, but your mate over there who's got a PSA of 0.3, we're going to look at him every 5 years. So we can be more intelligent and more clever about how we do PSA testing and prostate cancer testing by using some of these approaches. We also know that if you're aged 60 and your PSA is under 1.5, your risk of developing prostate cancer in the future is actually quite low. And so at the other end of the spectrum, we can say to some people, you don't need to have regular testing. You're at a lower risk, and so you need to have less frequent testing. And so that's just a little change that we're seeing at the moment with regards to how we can test. Now, it's not a line in the sand. It's not like the goal line where you step over the line and suddenly you're in trouble. It's a spectrum. And we do know that even men with low PSAs can still have some prostate cancer. And so even if your PSA is under 2, you've still got a 1 in 5 chance of harbouring some prostate cancer. But the higher the number, the higher the risk. And it's a spectrum. And that's why it takes a little bit of interpretation to identify who should be further investigated and who should not. Now, this is just a one slide looking at the debate. Why aren't, I'm sure you guys have a fairly strong opinion that men should be offered prostate cancer testing, and I agree, and I think well-informed men should be offered prostate cancer testing. But there is a pro and a con. The test is fairly simple. It's a blood test and a physical examination. We do know that the earlier you detect prostate cancer, the better the cancer outcomes, meaning cure. We do know that treating prostate cancer with surgery or radiation therapy improves survival. We actually know that the earlier you treat people, the lower the risk of the more troublesome side effects, because the less invasive, less extensive the treatment needs to be. And I think this is an important one which is often understated. When you're at the RSL club and you've had your mate over there and your mate over there who's been diagnosed with prostate cancer, if your result is low, that's actually quite reassuring. So there is a benefit to a lot of men from having a normal PSA test. Now, on the other hand, there's no doubt that, you know, if you've got a PSA between 4 and 10, you've got a 1 in 3 chance of having prostate cancer, which means you've got a 2 in 3 chance of not having prostate cancer. And there is some anxiety that goes along with having an abnormal test. Not all cancers are going to be picked up using PSA testing. So it's a good test, but it's not a perfect test. If everybody had a PSA test tomorrow, my colleagues and I would be overrun, and we'd be doing biopsies, you know, left, right and centre for the next 2 to 3 years. So there is a sort of a logistics issue that needs to be considered. And so we do need to sort of be sensible about who has testing and who doesn't have testing. And this is the big one, that the public health officials and the US Preventative Task Force and many other groups, including our own College of GPs, are of the belief that prostate cancer testing or prostate cancer screening does more harm than good. And the reason for that is if you are diagnosed, I'll give you an example. If you're diagnosed in the United States with low-risk prostate cancer, you've still got a 90% chance of undergoing treatment, being offered treatment or being encouraged to have treatment. And in an ideal world, the vast majority of those patients with low-risk disease should be placed on surveillance, at least in the short to medium term. So in the United States and in Europe, there has been rampant over-treatment of low-risk disease, and that's one of the criticisms of prostate cancer screening. But that's something that we're actively addressing, and certainly the Urological Society, hand in hand with the PCFA, are putting in place appropriate strategies to ensure that we don't see that same wave of over-treatment as we see more widespread adoption of prostate cancer testing in the community. And one of the ways that we can do that is to use something called PRIUS, which is a database employing active surveillance. And it's my belief, and the belief of many of my colleagues, that we should be using more active surveillance for people with low-risk disease and treat those people when they need to be treated, not just as a knee-jerk reaction to a diagnosis of sort of a low-risk cancer. Now, it takes a bit of a, you know, you guys, the average patient will hear the C word and they'll sort of, you know, well, when can I have my operation or when can I be treated? And it's not an easy sell, but if you spend 15, 20, 30 minutes talking to patients and their family about the natural history of low-risk disease, the vast majority of patients are quite happy to go into a surveillance program. And I'll talk about that a bit later on. Again, that's something which is relatively new. It's certainly something which has become more prevalent in the 10 years that I've been, since I've been up here last. And I think that is one very important strategy to minimise the harm but still maximise the good. Now, PSA can be abnormal for a number of reasons. It can be abnormal because you've got an enlarged prostate. It can be an inflamed prostate, bladder infections, being unable to pass your water. Certainly ejaculating in the previous 12 to 24 hours can put your PSA up a little bit. Certainly having a prostate biopsy can put it up. People who ride huge numbers of kilometres per week, like all of you guys do, on their bicycles can actually have a higher PSA than their peers, and sometimes it's just raised for no good reason. So what's a sensible way of looking at prostate cancer testing? If you're over the age of 40 and under the age of 70, and you know you didn't have a heart attack last week and sort of a stroke the week before, and you're going to live at least 10 years, men should consider being tested. More so if there's a family history, and that test should involve the blood test and the physical examination. And that's basically what the Urological Society is saying. And again, our wearing the other hat with the PCFA, a very similar message. We recognise that it is a major health problem in Australian men, New Zealand men. We don't advocate the mass population-based screening using PSA at this point in time. I don't think the data is there. And I guess we don't have the data to support a program akin to the mammography and the cervical cancer screening at the moment. However, there is very clear evidence which has emerged in the last 3 to 5 years that if you do have screening, if you do have regular testing, your risk of dying of prostate cancer over sort of 15 to 25 years can be reduced by up to 46%. Now, if you go back to the earlier slide, and there are 3,300 men dying of prostate cancer every year, that's about 1,500 men per year that wouldn't die of prostate cancer. If you look at the statistics in the States, they're probably talking about figures of 10,000 men per year that whose lives might be saved by regular prostate cancer testing. So it's a pretty fine line, and you know, the debate about whether we should have population-based screening or selected prostate cancer testing is, it's a grey area, but there's no doubt that there is a lot of benefit, a lot of good that can come from regular prostate cancer testing. And the other statement we're making here is that there's a role for a test in the younger man. And it's no longer just 50 or 40 if you've got a family history. It's really 40 or 30 to 35 if you've got a family history. Because that PSA test at the age of 40 can be a powerful predictor of your risk of prostate cancer in the future and will enable us to sort of look at those people at higher risk more carefully. And the reality is men are living longer. This is a nice table, and I hope you're not, you know, it's going to be reassuring to you and not the opposite. But the older you get, the longer you're going to live. And the reason for that is that some of your contemporaries start falling by the wayside. They have work-related accidents. They're risk takers. They smoke and they drink too much. They drive cars. In this sort of age group, a few people are going to fall off their perch from cardiac, heart attacks and things like that. So if you get to the age of 70 or 80, you're obviously in pretty good shape, and you're going to keep living. And so the life expectancy keeps going up, which is why a healthy 70-year-old should be treated, offered treatment, in my opinion, because he's probably going to live to 85 to 90. And so that 10-year window keeps getting longer and longer. And so, as I said, those figures should be reassuring to you. I'm not quite sure when the superannuation runs out. David could sort of give us some guidance on that, some clarity. And I'm also told that the average retirement age for me is probably going to be down here somewhere. The rate Julia Gillard keeps winding out that sort of pension age, but anyway, another story altogether. This is what prostate cancer actually looks like. This is a radical prostatectomy specimen. And one of the challenges we have is that this area here is where BPH occurs, the benign enlargement of the prostate, and that can make PSA as well. So as you get older, your prostate gets bigger, and sometimes the cancers can be a bit hard to find. But this is highlighting the fact that it's often a multifocal condition. It occurs in different parts of the prostate. And that can, which is one of the reasons focal therapy has still got a little bit of work to be done before it becomes prime time treatment. But certainly, the bulk of the tumours occur in the posterior part of the prostate, and this is the bit closest to the rectum, which is why many of these tumours can actually be palpated through the backside. The Gleason Grading system, I'm sure you've heard of it. We talk about a grade, and then we talk about a score. It can be a bit confusing, but these are basically normal prostate glands, Gleason grade 1. These are very bizarre, abnormal, nasty glands, Gleason grade 5. And so there's a spectrum. And the further removed that your prostate cancer glands are from normal prostate glands, I think I said that correctly, the more bizarre the cells, the higher the grade. And then you combine those two numbers in terms of how prevalent it is in the prostate to come up with a score. And this has been around for decades, and it's still the best grading system we have. And if you've got a Gleason grade 6 tumour, that's a fairly well-behaved tumour. If you've got a Gleason score 10 tumour, that's a fairly poorly behaved tumour. And so if we're talking about kittens and tigers, a kitten is a grade 6 tumour, a tiger is a grade 10 tumour. And then it comes down to the grade of the tumour, and treatment options are based upon the grade of the tumour and also the stage of the tumour. And you can see there that tumour is actually confined within the prostate itself. It's an early prostate cancer, and it's very amenable to cure. This one started to grow through the capsule of the prostate. It increases the risk that some cells may have escaped from the prostate, and so, but most of those remain curable with surgery or radiation therapy. Unfortunately, when it's got out of the prostate, into the bloodstream, into the lymph nodes, then it becomes less curable, and we start looking at other options. And again, that's just another graphic showing prostate cancer, which is confined to the prostate. This is another type of staging system. We talk about T1, T2, T3, or we talk about stage 1, 2, 3, 4. But you can see there that's a bulkier tumour which is confined to the prostate. That's a bulky tumour which is starting to grow into the seminal vesicles, and this one's starting to grow into some of the surrounding tissues. So there are a number of options for treating prostate cancer. Now, there is a big difference between active surveillance and watchful waiting, which I'm going to come to, but these are some of the more conservative options. These are sort of some of the more recognisable treatment options for localised disease. And this is what happens once, like my poor old GP friend at 5 o'clock this afternoon, who turns up with a PSA of 827 and lymph nodes on a scan. We're going to be looking at some hormone therapy, him perhaps combined with a bit of radiation therapy. That's a sort of a slightly longer list, and I've put it there to show you that there's plenty of scope for confusion in terms of treatment options. And you know, we do have, if you're talking about an operation, there's the open approach, still a very good option. There's a keyhole approach, the laparoscopic approach, and then there's a robotically assisted approach. But at the end of the day, it's the same operation, just through a different access, if you like. So there's very little evidence, very little data to say that one of these is better than the other at this point in time. Brachytherapy is a good option for men with early prostate cancer, and then you've got some external beam options. And that can be external beam alone, or it can be external beam combined with some brachytherapy approaches. Now, I lump all of these as experimental treatment, and there's been, has anyone actually had HIFU before I go any further? Okay, good. HIFU went through a little bit of a phase of interest, but the medium and long-term results have been disappointing, and it's still very much a work in progress, and it's not something that I'd be offering as first-line therapy to anybody at this point in time, perhaps on a clinical trial, but not as mainly. And if we're talking about focal therapies, which again are experimental, they're being done on clinical trials. And when I say focal therapy, let's look at the breast cancer analogy. 25 years ago, everybody had a mastectomy if they developed breast cancer. These days, very few people have a mastectomy. They have a lumpectomy, and they have some treatment of the surrounding tissue to minimise the risk that it recurs. And there's a school of thought that says, well, if you've got just a localised prostate cancer, why not just treat the prostate cancer itself? Why do you need to treat the whole prostate? There is some logic in that. It certainly would be a way of minimising side effects. And focal therapy is currently under investigation. And the way that we're looking at focal therapy is to use localised HIFU or localised brachytherapy with seeds. And I think we'll be participating in a trial at St George shortly using brachytherapy as a focal treatment for people with low-risk disease. So again, lots of things happening in the background. Cryotherapy. No one say cryotherapy? Good, that doesn't work either. And microwave therapy. Microwave therapy basically involves heating the. I shouldn't be flippant about it. There are some situations where cryotherapy can have a role. Certainly, it has a role in salvage therapy. So if someone's had radiation therapy and the cancer's recurred, then cryotherapy can be a useful role. But I guess if you're talking about mainstream treatment options, standalone HIFU or standalone cryotherapy or standalone microwave therapy is really an experimental treatment, and I think these options are probably applicable to the vast majority of men diagnosed with localised disease.
There is another meaning for HIFU, high income for urologists.
Yeah, I have heard that, not surprisingly, and it hasn't got reimbursement in this country yet, and the reason is to get reimbursement it has to be shown in a very objective fashion to have comparable outcomes to the existing treatments and be cost effective and it fails on both of those counts as a standalone treatment, which is why it hasn't passed the regulatory process for Medicare funding at this point in time. So let's just talk about I know I've spoken about active surveillance as we go, but it's really for very low risk disease and low risk disease. And to put it into biopsy terms, you're talking about 1 or 2 cores of prostate cancer in the biopsy. You're talking about Gleason 6 or less, and you're talking about a PSA under 10, and you're talking about low volume disease on a rectal examination. So it's low risk disease. And many of these people don't necessarily need to be treated immediately. And I find it a bit frustrating when I hear that a patient's been diagnosed with prostate cancer and they're told that they need to have urgent treatment, because the vast majority of people don't need to have urgent treatment. You've got weeks and weeks and weeks to make up your mind, to seek a few opinions, to talk to your friends, talk to your GP, talk to other urologists, get second opinions, talk to radiation oncologists. You've got weeks and weeks and weeks to make up your mind as to what the appropriate treatment is. So men who rush in and have treatment are doing themselves a disservice. Some people consider this delayed primary therapy, meaning, well, if I could be cured now, or I could be cured in 5 years' time, why bring forward the side effects of treatment? Why not have treatment when treatment is necessary? And that's what we mean by active surveillance. Let's treat those people who need to be treated, and let's watch those people that can safely be watched. Treat when cure is necessary, basically. And you can talk about turtles and rabbits, you can talk about kittens and tigers. There's lots of different ways of describing it, but there is no doubt that many prostate cancers grow very, very slowly. There was an interesting study conducted in Scandinavia many years ago, and they went through a phase of not treating anybody. And so they've got this population of people who were diagnosed with prostate cancer and then were followed for 20 years. And if you've got a Gleason grade 6 tumour, the risk of you dying of your disease over 10 to 15 years is actually only 1 in 10 or thereabouts. So that means that 90% of those people could be safely watched for a considerable period of time. So that means what we're doing is we're identifying those people that need to be treated early, and we're reassuring those people that if they go into a proper program of surveillance, many of those people can avoid treatment and avoid the side effects of treatment for a considerable period of time. Watchful waiting is similar but subtly different. Watchful waiting is basically finding a relatively low risk prostate cancer in someone who's in their 80s with other medical problems. And what you're basically saying is that your risk of dying of prostate cancer is much less than your risk of dying of old age or strokes or heart attacks or whatever else. And so we'll treat those people when they need to be treated in the knowledge that prostate cancer is very unlikely to shorten their life, and that other medical conditions or old age is likely to sort of carry them off first. A radical prostatectomy, that's a fairly commonly performed procedure in Australia these days, and essentially it's a good treatment option for disease which is confined to the prostate. Now there are some men and some urologists who are treating more advanced disease with a radical prostatectomy, and there is some evidence to support that, and you can combine radical prostatectomy with radiation therapy in the event that it's not all removed or that the disease is not completely eradicated with an operation alone. What we're trying to do is achieve a trifecta, is one way of putting it, and that's in an ideal world, we control the cancer, we preserve continence, and we preserve erectile function. And that's not always possible, unfortunately, but the earlier the disease is detected, the more possible it is. Radiation therapy, with or without the use of hormone therapy, is a very commonly employed technique. I'm sure some of you in this room may have had some radiation therapy, and radiation therapy's come along in leaps and bounds in the last 20 to 30 years. We're giving a higher dose, it's more localised, and hence we're getting better cancer outcomes with fewer side effects. Standalone radiation therapy is usually given over 7 to 9 weeks. Short-term bladder and bowel symptoms can occur, but the results would say that you will do equally well if you have radiation therapy as you will do with surgery. So it's a little bit of a myth that, you know, surgery is a better option at curing the cancer. The data, the studies do not support that premise. And sometimes we might use some hormone therapy temporarily because there's evidence that for higher risk disease, the use of radiation therapy is more effective if you're given hormones beforehand. Brachytherapy is a form of localised radiation therapy, and we use these little radioactive pellets, and each one has about a centimetre of radiation that it gives off radiation over around about a centimetre around the seed. And if you have enough of the seeds in the right place, you end up with a cloud of radiation which envelops the prostate and kills the cancer cells in the prostate. And the advantage of this approach, it's really a day-only treatment for prostate cancer. And at St George Hospital, where we have a public program, we literally send patients home the same day without a catheter, and that's their treatment done and dusted. So it's a very good option for some men, and it's not an option for everybody. You need to have a Gleason score of 7 or less. To be qualified for Medicare reimbursement, your PSA needs to be under 10, and you need to have a relatively small prostate. But many men with localised prostate cancer are suitable for this treatment, and the advantages are basically a reduced risk of leakage of water or incontinence and a greater chance of preserving the erections in the medium term. So there are a couple of options. One is to do nothing, and that's the south of France option. But there is no doubt that with the appropriate diagnosis at the appropriate time, men can do very well. Now, I'm just going to spend just a couple of minutes talking about the spouses and the partners, because sometimes men don't necessarily talk to their partner, and that can have about the diagnosis, about the treatment, about the side effects, and that can have some flow-on effects, because in a study looking at the women of men who have been, the partners of men who have been diagnosed with prostate cancer, men and women in particular, report being poorly informed about the diagnosis and the prostate in general, and that men not talking about it often sort of compounds the problem. And sometimes women actually feel regretful that they haven't spoken up beforehand and they haven't been a bit more vocal about sending their partner or their husband along to be tested. And so women are a very important part of the management of prostate cancer, from the beginning of the diagnosis or the testing right through to supporting a man through the treatment. And I think it's important that we do not just focus on the men, but we focus on the women and the wives and the partners as well, because clearly they're all being affected by this. A couple of words about diet and supplements. There is very little evidence at this point in time that any of the complementary medicines will have a major impact on localised prostate cancer. And I find it very frustrating and disturbing that men shun conventional treatments, and they go off and they sort of buy stuff at great expense on the internet, and clearly they're not doing themselves any good. I have no problems with men supplementing conventional medical therapies with some of these alternative agents, but it's really important that we know what you're taking, because some of them can impact upon these conventional treatments. And certainly alternative therapy is quite common, and up to 55% of Australian men are seeking alternative therapies, and unfortunately very few are particularly effective. And you know, I'm not saying I saw this patient today, but I've seen patients like that, and unfortunately it's all too common. And we all know that the internet is a sort of a poorly regulated place, and you can spend a very large amount of money on a whole lot of useless treatments. And so finding that happy medium, talk to your urologist, talk to your radiation oncologist. I'll just flick through that. People talk about diet. What's a healthy prostate diet? It's really easy. A healthy heart diet is a healthy prostate diet. Lots of vegetables, not too much red meat, high fibre, anything that's good for your heart, anything that gets a heart tick on the cardboard box is good for your prostate as well. There are a few other special items. Cooked tomatoes appear to be useful. Vegetables are probably useful. Any soy-containing products are useful, but at the end of the day, a healthy heart diet is a healthy prostate diet. So we're winding up. There are some sort of more extreme options, but prostate cancer is a diverse disease. There is definitely part of a group in the population we should be actively seeking, looking at prostate cancer for, and early detection does offer the best hope of cure. And we need to talk about individualising treatment and who needs what. All treatments can have side effects. Fundamentally, when I diagnose someone with localised prostate cancer, I say, well, all these treatment options are going to give you a very similar outcome, but the logistics and the side effects of treatment are going to be different. So that's what we should focus on. You make a decision between surgery and radiation therapy, not the outcomes, because the outcomes are going to be good and they're going to be equally good. Let's look at the side effects and let's look at the logistics of treatment. So men over 40, consider a blood test. Family history is important. PSA test is important. The rectal examination is important. Treatments are varied. Treatments can have side effects, but fortunately we can manage those side effects most of the time, and that early detection is very helpful. So that's really the my 45 minutes or thereabouts, and I appreciate the opportunity, the invitation to come and speak to you men and women tonight, and I'm very happy to take some questions.
Thank you, David. An excellent presentation. The first one from Brian.
Thank you. I've certainly learnt a lot from what you said. I had my full radical prostatectomy. I think I'm still suffering from anaesthetic a month ago, and my PSA was 2.8, and in the 3 years up to this time, and when I went at 77 to have my PSA, it was 4.1. Now, the doctor had been doing a rectal examination every year, and he says, your prostate is so small and soft, I'm sure you haven't got any problems. But this year it went up to 4. And he said, oh, I don't like that. It's probably just an infection. We'll treat you with an antibiotic. And nothing happened, so he said, I want you to go to a specialist. I'm asking you all these because my specialist's overseas, and I'm a bit worried about things that I'd like to have asked you, which you have helped me with tremendously now. Anyhow, I had the rectal robot, but also before that, they did the rectal check and found the biopsy, gave me a Gleason of 8, and of course, the doctor said, what do you want to do? And I said, well, is it bad? And he said, yes. We've tested, it appears to be in the prostate, but when he took it out, I'm now told, and I haven't had any conversation with the doctor since, he said it's outside the prostate. Now, my question is it outside the prostate? Does that mean it's going to spread rapidly, even though it has been taken out? Or what sort of treatment would I be subjected to at this stage?
All right. Well, it's very hard to talk about individual circumstances, but what I can say is that if you have a radical prostatectomy through whatever approach, the prostate is looked at very carefully under a microscope, and a pathologist will look at the volume of the tumour and whether there's any spread beyond the capsule of the prostate, and also whether that spread has gone to the edge of the tissue that's been removed. And so you can still have prostate cancer cells that have spread beyond the prostate, but a negative surgical margin, or you can have a positive surgical margin. Now, there's increasing evidence that both of those groups can benefit from some radiotherapy. So depending upon individual circumstances, some patients might be offered radiation therapy afterwards, which can reduce the risk of the cancer coming back. So the best type of cancer is in the prostate if it's been removed surgically, and there are different grades of spread, and you may well be offered some radiation therapy to reduce the risk of it coming back.
You suggest having that?
Just a sec, Brian. You can't
Very easily have a conversation.
So you would suggest having that in the immediate future?
No, usually you would wait until you've healed up and you've fully recovered from your operation. But again, you may or may not need the ray treatment. It's very hard to talk about individual circumstances without, pathology reports and the like. But you wouldn't have it immediately. You'd wait, several weeks, a couple of months until everything had healed up.
And I know this is probably unethical, but 2 weeks ago I developed a lot of soreness in the actual testicles and behind. I couldn't contact the surgeon. I've contacted my GP and all he's done is put me on antibiotics, said wait till you see your surgeon again. Is that normal, or that one can have this pain above the testicles?
I mean, you're only a month down the track, so after your operation, so there's lots of healing and inflammation which is settling down, and so again, a bit difficult to sort of talk about individual circumstances, but a few aches and pains after the operation for several weeks is not uncommon.
Next.
My name's Peter. One of the slides you put up indicated that 3,300 people will die, or males, will die from prostate cancer. Is that from prostate cancer detected or undetected? Or diagnosed or undiagnosed?
Well, that's basically a diagnosis which would come off a death certificate. That's basically how where those statistics come from. So all of those men would have prostate cancer confirmed. Some of them have it detected at an early age and they have treatment and it comes back. Others might present with advanced disease. So there would be quite a spectrum, but they would be 3,300 men dying of complications related to prostate cancer.
Next question. Okay, well, I'll
You're all
ask.
experts. That's terrific.
Yeah.
I've done a good job.
Well, they are a well-educated group, but I'll ask one. The old adage of comparing whether you have a radical prostatectomy or radiotherapy, the suggestion years ago, and it's used often, is that if the two treatments are equal, then there's a school of thought that suggests that the radical prostatectomy would be the best way to go, because if that fails, then you can follow that up with radiotherapy. But it's not necessarily the other way around.
Well, I've heard that once or twice as well, and it's not necessarily true.
No, that's what I want to
Yeah, the
clarify.
reality is that the vast majority of people who have treatment for localised disease only need one treatment option. They don't need a second option.
Yeah.
So if you had surgery and the cancer's been found early, most people won't need any radiotherapy. And similarly, if you have radiation therapy, be it brachytherapy or external treatment, the vast majority of people don't need a plan B. They don't need a secondary form of treatment. There's no doubt that if you do operations on more advanced disease, then you might need some radiation therapy, but that's really a treatment choice that some patients will take on in conjunction with their urologist. But for the average patient with early prostate cancer, one treatment is all that you need. And the second part of that is it's not quite true, because in the unlikely event that your cancer does come back after radiation therapy, you can have a radical prostatectomy. And it might be a little bit trickier, but it's certainly feasible, and it's certainly practiced in a widespread fashion around Australia. So you shouldn't feel that you're hedging your bets by going with a radical prostatectomy first. There's no doubt that sort of well-performed radiation therapy is an equally good option, for some people a better option, depending upon their individual circumstances.
Yeah, good. Thanks, David. Graham, you're not doing too well over that side. My side's doing all right.
Just another query. Again, it came from one of your slides you showed, and it seemed from the slide that the progress or the process which is undertaken, in other words, radical, and then other treatment, your slide seemed to indicate that from a radical, the next step more than likely would be radiotherapy. But that's not necessarily the case, is it? I mean, you could go from radical to, and your PSA is still slightly elevated, you could go to ADT.
The treatment options that I put up, if you remember, there were some conservative options, active surveillance and watchful waiting. Then there were treatments of localised disease, and they're all standalone treatments, and they're equally likely to cure most people. And so one doesn't flow onto the other, and most of those are standalone curative treatments. It's really in the event that one of those treatments doesn't work, that's when you'd be looking at some hormone therapy, or when somebody presents with disease which is already outside the prostate, and we're not talking about cure, we're talking about controlling the disease for as long as possible.
Okay. Good one.
With all the problems with PSA testing and so on, what would your recommendation be in relation to a doctor who doesn't perform them? Which is a school of thought, of course, with some of them that won't do it. My case was I had to relocate, so I changed GPs, and the second one ordered a PSA test as well with the blood test. Would you, with family history and things like that, of course, you'd stand up and say, well, I want a second opinion, but in my case, that wasn't an option, because there hadn't been any incident of prostate cancer in the family, but when they finally got their act together, I had a PSA of 160. I had the cancer that stage had spread, so the only option available to me, of course, was external beam radiotherapy. That was 7 years ago, and I'm still all right, but with 6 monthly visits to the oncologist, so he's sort of keeping his eye on it.
Well, that's a good outcome then, because obviously you had a bit of a problem to begin with. I guess your question comes down to what GPs should be doing. And what GPs should be doing is having a discussion with their patients as to the advantages and disadvantages of the PSA test and prostate cancer testing in general. And one of those earlier slides had the pros and the cons. And we're currently sort of working on a decision aid that GPs will be able to use to talk to their patient about the pros and cons. But at the end of the day, if a gentleman who's 35, 45, 55 or 65 wants to have a PSA test, he's entitled to have one. And if that particular GP won't do it, he's skating on pretty thin ice if the patient says, I want it done. But at the end of the day, have a chat to another GP. But a GP would be in a difficult position if he refused to do a PSA test and that person was subsequently shown to have prostate cancer.
Well, I've got two sons in their 50s.
Graham, you need the microphone, please.
I have two sons in their 50s, and knowing my history, they've asked for PSA tests, and there's no problem in relation to that. But the problem is if you don't know that you've got it, or
which is why public awareness is very important, and meetings like these are very important, and the role of PCFA is of invaluable assistance to men, because it is a source of confusion, and you hear stuff in the media all the time and you don't know what to do. Well, I think there are some very good resources out there to help people make up a decision regarding whether they should be tested or not.
Graham?
Yeah, your slide indicated in relation to brachytherapy that in your hospital you only use the seeds. I think a lot of our members have had seeds plus external beam radiation. Could you tell me if it's just a different procedure that doctors choose to take, or are there reasons why some people have one and the other?
That's a very good question. There are two types of brachytherapy. There's low-dose rate brachytherapy, which are the seeds, and there's high-dose rate brachytherapy, which I guess is commonly known as the rods. The low-dose rate brachytherapy is a permanent implant, and those seeds just stay there minding their own business for the rest of your life. The high-dose rate brachytherapy is usually the little plastic tubes put into the prostate in an operating theatre, and then you have 2 or 3 doses of radiation therapy down the tube. It's the latter, it's the high-dose rate brachytherapy, which is usually combined with external beam radiation therapy. And if you want to think about it in a simplistic way, the low-dose rate brachytherapy is a little stick for a low-risk or intermediate risk cancer, and the high-dose rate brachytherapy is the biggest stick for a higher risk cancer.
Good way of looking at it. Anne?
Thank you for your informative talk.
Thank you.
How soon after a prostatectomy do you have your PSA done again and have an altered reading?
Yeah, that's a good question. Usually 6 to 8 weeks after the procedure would be a good time to do it. You could do it a bit earlier, but you just run the risk of getting a result which is not accurate. So certainly 6 to 8 weeks is probably a good time to wait.
Tony?
Yes, in the guys in the dilemma of trying to choose between, say, radical prostatectomy and brachytherapy, and I know myself, I agonised over this for quite some time. But in the literature that I was given at the time, one of the reasons I chose the radical was that, as you've now said, it's not really correct, that if you have external beam and there is some problem and you want to have a radical to follow, you can't have it. The second was that in respect of the pathology, after a radical, they've got the prostate, they can cut it up and see exactly where it's gone to and if it's contained within the capsule. How do you tell that if it's just external beam?
Another good question. You monitor the PSA, and after effective radiation therapy, your PSA comes down and it stays down at a very low level. So you just have a different threshold. With a radical prostatectomy, the PSA should be very, very low or undetectable. With radiation therapy, there are different parameters which we would use, and we'd look at trends in PSA to determine whether it's been eradicated. But certainly after some of the brachytherapy techniques and some of the external beam techniques, I'm seeing patients who are sort of 5 years down the track with PSAs of 0.1 and 0.2. That's very, very low, and that's a very strong predictor of an excellent outcome.
Yeah, well, I know in my case the Gleason, based on the biopsy, and there were 4 needles out of 12 that were positive, was 3+3. So, but the post-operative test on the pathology of the removed prostate, it was actually 7. It came up to 3+4. So that's the reason I chose it. I thought, well, I can't. If it needs to go further, I can't have the second option because of having had the first and the second was to be able to tell whether it's contained within the capsule or not.
Well, in the unlikely event that radiation doesn't work, you can have more radiation, you can have surgery, you can have cryotherapy. There's all sorts of ways of what we call salvaging the situation if the primary treatment has not been completely effective. But the reality is if you have the right dose to the right place with radiation, the likelihood of you needing a supplementary treatment is very, very low.
Yeah, it's certainly improved. I had mine over 4 years ago now. It certainly improved the ability of the radiation therapy even in that period of time. Would that be right? Or yeah. Okay, thanks.
One last question. Thank you, Graham. Look after that woman.
I'm not going to let you get away, David. Just getting beyond having treatment and getting to the rehabilitation stage,
Yep.
How long out from a radical prostatectomy do you see fit for men to think about having a penile implant if they've got ED?
Well, the rehabilitation and the recuperation after surgery, there's lots of different facets. You've got these the early 6 weeks getting over the operation. Some men are continent immediately, some men are potent immediately, and if they've had a bilateral nerve sparing operation, we didn't go into the the nitty gritty of surgical technique, but there are some men who have good erectile function within weeks of having their treatment, be it surgery or radiation therapy. Continence can take up to 12 months or even a bit longer to improve, and so men should continue doing pelvic floor physiotherapy after their operation in particular as a lifelong exercise. As far as erectile function goes, the sort of steps would be to try some of what we call PDE5 inhibitors, or the sort of the Viagra class of drugs. They're effective for some men after treatment for prostate cancer. There are some injectable agents. One of the better known ones is called Cavaject, which we can use basically pretty much straight away after an operation. As far as a penile implant goes, it depends. There's nothing to stop you doing it sooner rather than later once you've recovered from the surgery. But it takes a while to determine that the other less invasive options aren't going to be effective. And so, there's no right or wrong answer. I would have thought that getting over the operation, trying the other treatments, digesting the benefits of the penile prosthesis surgery. Usually it's something that might be done 6, 12, 18 months after the operation.
Good. Now, just checking to see if there is one final question. That was it, I think. Okay, well, it remains for me to say thank you very much, David. We appreciate your trip up here. We hope you think it's worth it. We certainly
Absolutely.
did. Could you help me thank David? Thank you very much.